Hello, my name is Ed Bottomley with the Michigan Medicine Department of Communication, and I will be your host for today's live stream. Quitting smoking can greatly reduce your risk of cancer, especially lung cancer, which is the leading cause of cancer deaths among men and women. Today's live Q&A will focus on all the benefits of quitting smoking for lung cancer prevention, as well as other diseases, from Michigan Medicine pulmonologist Dr. Doug Arenberg and tobacco specialist, health educator, Alena Williams. Those are our two experts for today. Dr. Doug Arenberg is the University of Michigan professor of pulmonary medicine and leads the Rogel Cancer Center's lung cancer screening program and is part of the multidisciplinary lung cancer team. Alena Williams is a Michigan medicine health educator and tobacco treatment specialist. Since we're doing this live stream remotely, please pardon any technical interruptions that happen during the broadcast. And first, a few housekeeping items. You can submit questions at any time, even now, for our experts to answer during the Q&A portion of today's chat. Questions can be submitted by commenting on this video, but please note that your name or your profile name will be visible to others participating. If you can't stay for the whole chat or want to share the recording with a friend, a video of the chat in its entirety will be available on our Michigan Medicine Facebook page, our UMich Medicine Twitter account, and the Michigan Medicine YouTube channel. Now let's move on to our questions with our experts, Dr. Arenberg and Alena Williams. The first question that I have up, Dr. Arenberg, this month is Lung Cancer Awareness Month. Can you tell us if and why smoking is the leading cause for lung cancer?
Well, one of those questions is a lot easier than the other. There's no question that the epidemic of lung cancer that the world has seen in the last 100 years is directly attributable in very large part, if not entirely, to the increase in the use of combustible tobacco. That's not to say that one can't get lung cancer as a non-smoker. We see this quite commonly, but the overwhelming majority of people with lung cancer were victimized by their use of combustible tobacco, a lot of which was prompted by a very effective marketing machine put together by the tobacco industry nearly 100 years ago. Why tobacco is not entirely clear, other than we know that when one uses combustible tobacco, there are thousands, literally thousands of chemicals that come with the most addictive substance in the cigarette, which is nicotine. Cigarettes are precisely and really extensively engineered to deliver nicotine rapidly to the brain, thus producing a very dependence-inducing rush, if you will, from nicotine. The rapidity with which the nicotine gets to the brain from a cigarette is faster than any other tobacco product, and so it's quite addicting, and that addiction comes with the price of these other several thousand chemicals, many of which are what we would call genotoxic. They are toxic to our DNA. They induce damaged DNA in a way that's very effective at causing normal lung cells to turn into cancer cells. And so year after year, decade after decade, exposing yourself to combustible tobacco has countless bad effects on the health, and this one that we're talking about in particular, of course, lung cancer is an area that has been the focus of my career, is particularly devastating.
Apologies, I was muted for a second. The next question that I have up, is there a screening tool for lung cancer?
There is. This is relatively new compared to other cancer screening programs that are public health based mass screening programs. The key for any cancer screening program is to recognize that all cancer screening is something that we do on people who are asymptomatic, people without symptoms. That is the definition of the population who should be undergoing screening. And so about, not quite 10 years ago, a clinical trial that was enormous in its undertaking concluded with evidence that showed unequivocally that low dose annual screening in people with high risk for lung cancer with CT scans, low dose CT scans done annually were a good way to reduce one's chances of dying from lung cancer. Now, part and parcel of that effort is to incorporate tobacco cessation into every lung cancer screening program, because when you do so, you amplify the benefit of screening. In fact, tobacco cessation by itself is much more effective than lung cancer screening, but combine the two, you really amplify the effect of both of them. And it's why we're very lucky to have folks like Alena, who I consider sort of a force multiplier in terms of helping us spread the word and allow people who are ready to make a tobacco cessation attempt allow them the greatest chance at success. So you really can't talk about lung cancer screening without talking about tobacco cessation.
Fantastic. Thank you for that answer too. And the third question that I have up reads, if I never smoked, but I know people who got lung cancer who also never smoked, would screening be right for me?
This is a difficult conversation to have, because I've already alluded to the fact that one doesn't have to be a smoker to get lung cancer, but the fact remains that the most compelling risk factor that we are able to detect for lung cancer is exposure to combustible tobacco smoke. Now, I am constantly contacted by people who've had family members who had cancer that didn't smoke, and they want to know if they should be screened. And the fact of the matter is that right now, our screening tools are not effective for that population of people who, although their personal experience really affects their outlook on life, their actual risk for cancer is still quite small, even compared to somebody who's been a minimum smoker. So if you look at it from a population basis, which is how screening for cancer has to be evaluated on a population basis, if you take people who don't smoke and screen them, what you're going to do is find a lot of false positives, and those false positives might lead to potential invasive procedures, and those procedures have potential harm. So when you take people whose risk is very difficult to measure, but we know it's lower than that of someone who's been a lifelong smoker, even with a family history, and offer them screening, you introduce into that population the potential for a lot of harm, which can only be recommended if it's balanced by potential benefits in form of reducing your chances of dying from lung cancer. So it's a very difficult and frankly unsatisfying conversation to have, because they don't like the answer. The answer is, I can't recommend screening for people who don't smoke. That's really what I end up having to tell people. And some will find a way to get screened anyway. And I caution them against overreacting to what they find on the screen, because a lot of us do have pulmonary nodules. They're quite common. That's what we're looking for on screening tests. But without going too far down that rabbit hole, in a word, no, I don't recommend screening of individuals who never use combustible tobacco.
Thank you for that. The next question I have up is for you, Alena. The question reads, how do you address people that say, I have tried everything, but still can't fight off the cravings to smoke? How can I get motivated, and how can I succeed at quitting?
Yeah, this is a great question, Ed. The reality is most people want to quit smoking, have tried to quit without success, and even feel a little stuck in this cycle of trying and not succeeding. So the first thing I would recommend, because I can't give somebody the motivation, but I can help them find what their motivation is for that person to ask themselves, what do you like about smoking? I ask that question frequently, and frequently I'm met with absolutely nothing or very little. And that's a very powerful statement for someone to sit with. This thing that you do probably every day, that you spend money on, that is impacting your health, is giving you nothing or very little. So, really kind of sitting with that to build the motivation around change is something that we do. And then other responses that we kind of get to that is thinking about how people really use smoking as a means to help them relax or calm down or manage stress when they don't have any other tools or techniques that they're using to help with stress management. So helping them explore other ways to cope with stress, cope with life is something that is integrated very deeply into tobacco treatment. It's seen to me and my tobacco treatment specialist colleagues as a lesson in self-care and self-compassion to really identify the thing that your mind and body needs. So yes, you need that break. Yes, you need stress relief. But how do you get that without a cigarette and other things that cause harm? The other question that I would ask someone that is finding it hard to quit and get motivated is what would it mean to them to actually quit smoking and what barriers prevent them from making it happen? Once we can answer those questions, we can begin to really identify what we need to put in place to make quitting a real possibility. And that's what we do in tobacco treatment.
Thank you for that. I think that was a really comprehensive answer that you gave there. The next question, I believe this next question that we've got coming in, what are the components of a comprehensive tobacco treatment program?
Okay. Yeah, so there are a lot of misperceptions about what tobacco treatment is. Often, when Dr. Arenberg will refer a patient to us, we'll call them, introduce myself, and you can hear the fear in the patient's voice. Oh no, I know I need to quit. I know it's bad, and that is, far from what I'm there to do. People know it's bad. Most people want to quit, so what tobacco treatment isn't, it isn't there to shame, blame, or guilt our patients into quitting. What we use is an evidence-based approach to behavioral change, really focused on those motivations of the patient. So, where's that motivation, and how do we collaborate with the patient to develop a very individualized treatment plan, just like their tobacco use is very unique to them? Their plan is going to be unique as well. And we have to take into account, of course, their medical history. We look at their tobacco use and draw strength from changes. I've worked with people that have gone from smoking, 5 packs a day to 1 pack a day. It's still a lot, but it's not five. And we can definitely draw from those strengths. The other big thing that we want to do is this is addiction treatment. Like Dr. Arenberg said, nicotine is one of the most addictive substances in the world when it's smoked. So really kind of providing evidence and education around what that addiction is, how it shows up in someone's life, and what we can do to treat that. And one of the best tools that we have as healthcare providers is nicotine replacement therapy and cessation meds. These products can actually triple someone's chance of quitting successfully, but they're often underused or not used properly. So, providing the education around the use, making the appropriate recommendations, and also finding ways to get the products at low cost or no cost for our patients is a huge part of tobacco treatment. When we look at our outpatient tobacco treatment program, it's actually 6 sessions. The first 3 sessions are really built around building that quit plan. So, looking at a patient's triggers and cravings, what's in their life or maybe a part of their culture that contributes to their tobacco use, and help them develop some really evidence-based coping strategies to address those triggers and cravings. Following that, we provide some information for relapse prevention and really lifestyle change. A lot of what we do, it is stress management and giving people the tools and techniques to cope with the stress that comes with life and find healthy ways to manage stress.
Fantastic. One of the best parts of this live stream so far is to see both of you nodding. When one person's talking, there's nodding from the other side. I have actually a question that can involve both of you here. And this is a big, broad question, what are the immediate and long-term health benefits to quitting smoking?
Let me just start, Alena.
Go for it.
So, there's literally no organ system that is not negatively impacted by combustible tobacco. I would say that as a pulmonologist, of course, people are often asking me about the benefits of smoking from a pulmonary standpoint. What's going to happen? Well, before any benefit really accrues to the lungs, the first thing you'll see is a reduction in blood pressure and heart rate, and an almost immediate reduction in the risk of stroke and heart attack. So for people with cardiovascular disease or people without cardiovascular disease, your risk of the major cause of death in the Western world, which is cardiovascular disease, goes down immediately with smoking cessation, because everything that comes with a cigarette is bad for the cardiovascular system. The benefits to the lung take longer time to accumulate. The one exception to that may be a patient who has asthma. And if you stop putting burning tobacco in your lungs, smoke is simply particulate matter, which is a particularly irritating exposure for the lung lining. If you stop putting irritating particulate smoke in your lungs, your asthma will get immediately better. But long-term, things like the amount of cough, the amount of phlegm that you produce, the development and worsening of emphysema immediately begins to reverse. And over time, one's risk of developing lung cancer goes down significantly. But you accumulate this reduction in lung cancer risk over a period that's measured in months to years, not days to weeks. As I said, there's literally no organ in the body that is not affected by tobacco use. Alena, I don't know what else you could say about the immediate benefits and intermediate term benefits of smoking cessation to your clients.
Yeah, so prior to COVID, when we were in our office, right now we're working remotely, which it has its pros. We're able to reach a wide range of patients since we do serve patients all across Michigan. We're serving more patients from the Upper Peninsula and a little farther out. But during that first intake assessment, one thing we would do was measure carbon monoxide levels. So carbon monoxide, a toxic gas we're all breathing in because we have cars and factories in our environment. But for people that smoke, because there are 7,000 chemicals in tobacco smoke, 250 of them are toxic, including tar, carbon monoxide, almost 70 carcinogens. There are higher number of these toxins. So what we find is with high levels of carbon monoxide, your organs aren't getting that healthy oxygenated blood. So it's organ damage over time. What we see immediately after quitting smoking, within 8 hours, carbon monoxide levels in the blood drop to that of a non-smoker. So that's one thing, like really quickly, a carbon monoxide test, we call it kind of our stethoscope within tobacco treatment. We can give you a really quick measure of the health improvements. Blood pressure will return to normal after 20 to 30 minutes of not smoking a cigarette. Improvements in your hand and feet are huge. And then, of course, those long-term impacts in lung functioning, cardiac functioning. And then for our patients that are undergoing cancer treatment, we really want to stress the benefits of quitting smoking. We know that for patients that quit smoking during cancer treatment or before cancer treatment, they have improved treatment outcomes, whether it's radiation, chemo, surgery. They reduce their risk of a secondary cancer. And also, some of those treatment related side effects like nausea definitely are decreased as well.
Yeah, I would
Thank
add
you.
to that if I
Go
could.
ahead.
The Surgeon General report that comes out every few years on tobacco and health, the most recent one in 2014, really just absolutely extensively cataloged all the cancer-related improvements in health outcomes that happen when a current smoker is able to become an ex-smoker. And the results were really, I wouldn't say surprising, but just absolutely staggering in terms of their potential benefit. Many oncologists, I think, have practiced under perhaps a misconception that by the time they meet their patient, it might be too late to stop smoking. And I want to really emphasize this. Nothing could be farther from the truth. When you ask oncologists and their patients, when they start their cancer treatment, what are the things that are important to you about this journey that you're on? Things like medication side effects, the outcomes of treatment. Does my cancer respond to the treatment? What happens if my cancer goes away? Am I going to get a second cancer? every single one of those is favorably affected by the smoker who's able to quit smoking at the time of their diagnosis. And so we have made a really focused effort with Alena's help in the Cancer Center, which you see behind both of us on our backgrounds, is to make sure that every cancer patient gets the opportunity to make and succeed at a tobacco cessation attempt if they are currently smoking at the time of a diagnosis. Even people with advanced stage cancer that is incurable are going to have better outcomes and better quality of life if they can stop smoking. And so there literally is no time that is too late to stop using combustible tobacco.
Thank you. Thank you so much for that, both of you. The next question that we have up for you, Dr. Arenberg, what do you say to patients that want to quit smoking but don't like using medicines and want to use electronic cigarettes as a means?
So the first thing I say to anybody who tells me they want to quit smoking is I say, that's wonderful. I'm so glad that you've made that choice. Absolutely have to use positive reinforcement. On a public health level, stigma works well to get people to not smoke, but that has no place in the exam room in a one-on-one interaction with someone who's struggling with addiction. So I absolutely applaud their intent to quit. I will tell people in general that if you're going to make a quit attempt, if you haven't already done so, and perhaps even if you have, the first thing we want to try are the FDA approved medications, and we can come back to what those are. But what the FDA approved stamp means is two things. One is that it's established the safety of that medication long before anybody's ever tried to answer the question, does it work for what it's being sold for? But once the safety has been established beyond a shadow of a doubt, then companies who want to sell a medication are asked to bring data to the FDA that says this medicine does what we say it does. And so the FDA approved medications are always going to be the first choice. But the fact of the matter is that there are 20-some million Americans who are laboring under the addiction of nicotine. And many of them have tried FDA approved medications time and time again and haven't been able to. And they'll come to me sometimes and sheepishly say, I've been using electronic cigarettes, and I can see them brace for the impact, if you will, of the judgment that they're expecting to get from me. And so what I tell people is that if you can completely stop combustible tobacco only through the use of electronic cigarettes, for now, you have my support. It's not an FDA approved strategy. It's not an FDA approved pathway, but there are countries like the United Kingdom where it is in fact a recommended approach. And there is a lot of debate amongst public health experts as to whether that should be the case or not. If you want to start a rigorous debate in a public health meeting, talk about this topic. But I will say this, there's two aspects to the electronic cigarette debate that I think that we have to reconcile. One is if we take every single smoker on the planet, every single person who smokes tobacco on the planet, and switch them today from combustible tobacco to electronic cigarettes, I have no doubt in my mind that the net benefit in public health would be enormous. The problem is that we have an entire generation of youth who would never have dreamed of smoking cigarettes, who are now taking up nicotine dependence at alarming rates. So if there's a way for us to drive the wedge between the potential public health benefit of electronic cigarettes and the youth uptake of nicotine addiction, I would love to find it. So I do support people who tell me that they can't stop smoking, but through any other means aside from electronic cigarettes. I tell them they have my support because combustible tobacco is the enemy. We need to keep that in mind. But as the father of two teenage sons, who I'm grateful neither of them smoke, and so far neither of them have told me they've tried electronic cigarettes, but they see a lot of their friends doing it. That should concern all of us, because from a public health standpoint, we were really working hard to make nicotine dependence a thing of the past, and this is a major setback.
Absolutely. The next question that I have, what are vaping risks?
Well, so again, you're taking something that's not meant to be in the lungs and you're putting it in the lungs.
Sure.
There's really only one thing that should be going in your lungs, and that's air. Now, air has water vapor in it, right? And our lungs, our bodies are meant to have water vapor, but air has a lot of other things in it: dust and fungus and bacteria and virus and diesel particles and cooking fumes and cat hair and so on and so forth. The lungs are pretty good at dealing with these environmental things that have been around long since before we evolved as human beings. The lungs are built to work in this environment. The lungs are not built to intentionally vaporize solvents that can themselves turn into carcinogens when heated to the proper temperature. And the lungs, of course, are not built to become a portal of entry for nicotine, but as the tobacco industry has discovered to its great profitable benefit, delivering nicotine through the lungs is a very profitable but unfortunately fatal venture. Think of any other consumer related product, anyone on the planet, a consumer product that when used as directed kills 50% of its users. So we need to be very careful about what we put in our lungs. Quite aside from the epidemic that started just about a year and a half ago of vaping related lung disease, we knew very, very little about the safety, long-term safety. We still know nearly nothing about the long-term safety of the vaping epidemic. We do know that if you put certain things into electronic cigarettes, most of the lung injury cases that were reported about a year and a half ago were from people getting street products that were probably not the kind of thing you buy off the shelf in the drugstore. We knew that there were unknown risks. The vaping epidemic, if you will, and the vaping lung injury epidemic that happened a year and a half ago was a surprise. It's not over yet because people can still buy these things off the street, off the internet, and some of these things have unknown substances in them that are quite injurious to the lung. And just as recently as a couple months ago, I had a patient in the midst of the COVID epidemic in our ICU suffering from nearly end-stage lung injury as a result of vaping.
Thank you for that. That's a very tough question, so I appreciate it. Alena, did you want to add anything?
Yeah, Ed, I just wanted to add from like the treatment standpoint, because I often have people come to me and ask a question about using vape products or e-cigarettes to help with quitting. And I've worked with a number of people that have tried those products to help quit. And what we see often is dual use. So while people may reduce the amount of cigarettes that they're smoking, they're still vaping a lot. And a lot of those vape products have really high levels of nicotine in them. And because of that mechanism of delivery, inhaling it into your lungs, the chance for addiction is similar to that of a cigarette, because it again reinforcing those pleasure pathways that lead to nicotine addiction. So like Dr. Arenberg, I don't knock people at all for, trying whatever they feel is going to help them quit, but really trying to provide some education around the risks associated with it and the fact that these products have not been proven to effectively help people quit. And in high numbers, we see dual use, and the combination of the chemicals from tobacco smoke and these vape products can really come together and cause some serious health problems that we just don't know how severe they'll be because they're still kind of new. One thing that we do see with vape products is that inflammation of your cardiac cells, which can be very concerning. So my recommendation is always the use of the FDA approved medications. Oftentimes people want that hand to mouth motion to address that oral fixation that goes with nicotine addiction. And we have a product, it's called a nicotine inhaler. It is a prescription only medicine approved by the FDA that can give our patients some of that, again, very different from vape products, and they're completely safe. So I recommend talking to your provider, talking to a tobacco treatment specialist about effective options.
Thank you. Thank you both for that answer there. The next question, I have it for you, Alena, and it's a little bit of a circling back to a previous thread. What products make up nicotine replacement therapy?
Oh, okay. That is a good question. And I would say it depends on, so there are 5 different nicotine replacement therapy products. There is the nicotine patch that is kind of the standard go-to. Put it on once a day, forget about it. You get this slow, low dose of nicotine over time. Because it is a slow, low dose of nicotine, and the nature of cigarettes is a quick hit. Oftentimes people feel like those products aren't that effective, or it's not giving them that relief from nicotine withdrawal. So we like to put the patch in combination with some of the faster acting oral nicotine replacement therapy products. And those include the nicotine gum and lozenge. There's a nicotine inhaler, and there's also a nicotine nasal spray that we don't recommend a whole bunch, just because you are squirting something up your nose that contains nicotine, which can be kind of irritating. And it does give you, if we can get close enough to a cigarette as possible, it would be this nasal spray. So I kind of reserve that for the patient that has tried everything, tried things in combination, and are really at kind of their wits end with something to try.
Thank you for that, Alena. The next question that I have up, I'm also going to send to you. It reads, does smoking and disease affect people of underserved populations or areas differently?
Absolutely. And so there are huge tobacco-related health disparities, social justice issues within racial and ethnic minority groups, within the LGBTQ plus community, along communities of low socioeconomic status, and also by people with mental health and substance use disorders. And it's not because these more vulnerable groups just like to smoke more. It really is directly related to predatory practices within the tobacco industry, to really market and prey on these populations. Just a few examples would include in low socioeconomic communities, we often see lower priced tobacco products. And again, from a tobacco control standpoint, price points and taxes has been really effective in reducing tobacco use and saving lives. We also know that in certain communities, tobacco companies do about 10 times more marketing, and that point of sale marketing really can start initiation. And for people that are trying to quit, when you walk into a store and the cigarettes are right there in front of your face, that is by design and definitely contributes to relapse. Another huge issue within tobacco control is flavored tobacco products. And while we have done wonderful jobs with getting flavored tobacco cigarettes out of the stores and off the shelves, menthol remains the only flavored tobacco product. And that really is related towards who uses it. 9 in 10 Black smokers actually use menthol products, and it's easier to start, harder to quit. And that was really a push from the tobacco industry back in the 70s and 80s when these products became really popular. It's not that Black people just like the flavor of menthol. It was predatory practices within the tobacco industry to give financial contributions to Black organizations and leaders, to also go to schools or what they called urban field trips to pass out these products. And the other important thing to note about menthol is that because menthol is cooling, it's a deeper inhale. So oftentimes what we see for people that smoke menthol products, they get more nicotine, and they also have more severe, deeper lung damage. So thinking about tobacco control legislation, we really need to push for these flavored products, menthol, e-cigarettes, and things like that to be included. And so Black people aren't the bargaining chip for some of our legislation.
Yeah, I'd
Absolutely.
like
Thank
to
you for
add
that.
to
Go
that,
ahead.
Alena, the issue of menthol just really, really irritates me. It is a product that is designed to promote deep inhalation of tobacco smoke. And when you look at predictive models for lung cancer risk, what we find is that African Americans are at higher risk on a per cigarette basis. It's not that they smoke more, it's that per cigarette they're exposed to more carcinogens. This is not a genetic racial issue. This is a racism issue that has been manifested and perpetuated by the tobacco industry's insistence on the inclusion of mentholated brands that are specifically marketed towards African Americans across the board, and in ways that are really almost disgusting, that the tobacco industry has the audacity to do this, thinking that they're providing a service. And it's just really, it's so irritating to learn the truth about the tobacco industry and how they have perpetuated this on us as consumers. The menthol thing is something that I wish the FDA would get out in front of once and for all.
Yeah, definitely agree, Dr. Arenberg. And it's, oftentimes my patients that I work with that use menthol products, I like to provide them with the information, but I definitely do it cautiously because, again, to sit back and look at the reality of what's been able to happen and the death and disease that it has caused within this community, within my community, it can be that frustrating thing or upsetting that it can be a trigger for people to want to smoke. So really trying to provide the education, but also to let people know there are hope. There are some really strong, wonderful tobacco control advocates that are pushing for these bans. And I'm hopeful that one day, we will have the ban on menthol products and save lives. When you think about the tobacco industry, they're spending billion dollars a year on marketing. That just blows my mind. And like you said, Dr. Arenberg, to market a product that's going to kill half of its consumer base. So you spend $25 million a day, $1 million an hour to market these products that cause disease and death. It's mind blowing.
And when you look at what the states and other departments of health have in terms of their budget to counteract this marketing monstrosity, it's not sufficient. And now they have free access to the eyes and ears of our teenagers, which they refer to as replacement smokers. This is how the tobacco industry refers to teenagers in their internal memos. They have free access now through social media. It's essentially free. And so we are fighting an uphill battle when it comes to our attempts to market our ideas and the truth about tobacco.
Yeah.
Thank you. That was very, very eye-opening. Like you say, Alena, some of those things are absolutely mind-blowing. The next question that we have up reads, and I'll push this to Dr. Arenberg. This question reads, I was diagnosed with a bleb in one lung and a nodule in the other, and I've quit smoking 18 years ago. Do they ever go away? And what should I do?
Blebs are often the result of emphysema related to cigarette smoking. They do not go away, but they generally stop worsening. Blebs by themselves are not harmless. They can increase one's chance of getting what's called a spontaneous pneumothorax. That is, essentially your lung is like a balloon and it pops. Most people, they're found incidentally, and they are not major threats to health. Lung nodules do not go away. Most of them are benign. The way we produce, there's only two ways to prove that a lung nodule is benign, and I don't want to get into too big of a tangent, but one is take it out and the other is time. And for the vast majority of people, the appropriate option is to just monitor it. So many people have lung nodules, smokers are not. And again, I shouldn't say smokers, I should say people who smoke, and even people who don't smoke have lung nodules. They're quite common. They can be cancer, but many are not. Most are not. And generally they just need to be followed for a long enough time to show that they don't behave like a cancer would.
Thank you for that. The next question that we have, I'll push to you as well, Dr. Arenberg. This is an interesting one because I feel like you touched on this earlier on, just the devastating impact of smoking to so many different areas. The question reads, what other cancers or diseases are people at risk for with smoking?
So as time has gone by, there have been the link between lung cancer and smoking took decades to make, decades of very meticulously done clinical trials. And some of that was done as the tobacco industry fought very hard to sow distrust of these connections. As they were unequivocally made a connection between lung cancer and tobacco smoking in 1964, really kind of officially in the Surgeon General's report from 1964. Since then, the number of cancers that have been connected with combustible tobacco use, I think, is some like 40 or 50 other types of cancer, including blood cancers like leukemia, esophageal cancer, throat cancer, mouth cancer, kidney cancer, bladder cancer. These are basically the major causes of cancer-related deaths. And if you take all these, the only major cause of cancer-related death that is not more prominent among smokers than non-smokers would be melanoma, which is related mostly to sun exposure. So, the number of cancer-related deaths attributable to smoking is extraordinarily high. And again, as I said, if you could convert everybody from combustible tobacco use to some non-combustible form of nicotine, you could potentially have a long-term reduction in cancer. We wouldn't see it right away. These benefits, these health benefits, particularly cancer, which takes decades to develop, it may take decades to see a reduction in the rate of these cancers, but it will happen.
Thank you for that. The next question that we have up, lung function is affected by COVID-19. Can you talk to us about related risks due to smoking?
So COVID-19 affects a lot of things. Any cause of acute lung injury, which is when you hear of COVID-19 pneumonia, what you're really dealing with is what we call acute respiratory distress syndrome. Any cause of acute respiratory distress syndrome has the potential to cause long-term damage to lungs. And it will be a long time before we know what the long-term damage of COVID specifically is, but there's no reason really to expect it to be different from other causes of severe lung injury. We are seeing COVID induced changes in neurologic function, which I think are unexplained so far. There was early in the pandemic some suggestion that somehow through some twisted mechanism, nicotine might protect one from COVID. And right now the evidence is really strongly against that. Tobacco smoking increases the expression of a gene in the lung called ACE2. ACE2 is a receptor through which COVID infects your lungs. So if you have more ACE2 receptors, biologically, it's implausible to suspect that that would be anything but bad for you if you're exposed to COVID. So we do know that I think there's pretty good evidence now that smoking probably does increase one's chance of becoming infected, and smoking-related lung disease almost certainly is associated with worse outcomes than people who start out with healthy lungs. So the connection between smoking and any respiratory disease is complex but unequivocal, and I don't think that COVID is any different in that regard.
Next question, I muted myself again. The next question that I have, and I'm going to push this to both of you. This question reads, why do people gain weight when they try to quit?
Yeah, so one thing, if you kind of think about the habit or routine around smoking, there's this constant hand to mouth motion. If you smoke a pack a day, that's 20 cigarettes a day, you're at least doing this 100 times a day. So the habit or routine, oftentimes what we find is people replace that habit or routine of smoking with eating. So there's a lot that we can do to prevent, the weight gain that often comes. We tell people to plan for, healthy eating, exercise, but on average, people might gain 7 to 10 pounds within that first year of quitting. And for some people, that is not an option. So we want to make make it really clear there are things that you can do to prevent that weight gain, and just being aware of what your habit and routine is. Healthy snacking, moving. If you can't engage in a exercise program, can you walk? If you can't walk, can you do light yoga, chair stretches? Keep your body moving, and just be very conscious about what you're putting into your body.
Thank you for that answer, Alena. Dr. Arenberg, anything to add?
Not much. I think nicotine has been touted as an appetite suppressant, but I think you really hit the nail on the head, which is that there is a habit that needs to be replaced. As problematic as the addiction itself is, many people who overcome the addiction will ultimately succumb to a habit. We tend to retreat back to our comfort zones, which includes our habits when we're under stress. And so a lot of people will react to stressful events, which are unpredictable and inevitable. And none of us leads a life without stress. And I think I've often used the term that we are stress sharks. If we don't get it, we'll go find it. And those who find stress in their life will retreat into their comfort zone. And because it's unpredictable, these are often events that trigger people to relapse to smoking. But a lot of times it's just replacing one habit with another, and eating is a habit. There is a medication that minimizes some of the weight gain that one sees when stopping smoking, and that is Varenicline, which is one of the better tobacco cessation medications out there. We haven't talked about that. We can circle back to it, but it is the newest of the 7 FDA approved medications that are out there. And through its mechanisms, it may reduce some of the appetite stimulation that occurs when you rebound from nicotine dependence.
Thank you for that. And by the way, whenever anything is mentioned, Dr. Arenberg, you just mentioned that any links or any websites that you want to mention, we can go back afterwards and put those in the comments section for people to find. The next question that I have is for you, Alena. It's our last question for now. I will have a final wrap-up question for both of you, but this question reads, the American Cancer Society Great American Smokeout takes place the 3rd Thursday in November each year. Could you tell us a little more about this event and where people can find more information and resources to help with quitting?
Yes, yeah. So the Great American Smokeout, we call it GASO for short. It's been a part of the American Cancer Society for about 40 years. It's an opportunity to encourage people to use the date to start the journey towards a smoke-free life. It actually started with a high school guidance counselor who was doing a fundraiser for his students for college scholarships, and urging people to take the money that they would spend in a day on cigarettes and donate it to this college fund. And when you think about, we didn't talk a lot about that financial aspect. On average, someone that smokes a pack a day, it's about $2,500 a year. So thinking about that financial strain can really add up. So the Great American Smokeout, it encourages participants to use the date to either start a quit plan or do some planning in advance and actually use the date as their quit date. This year, GASO is taking place next Thursday. That's November 19th. So for those that are listening and thinking about quitting, you definitely have time to prepare and set those quit dates. This is an event that each year thousands of people across the country take this important first step to a healthier life and reducing their risk of cancer. Like we said, quitting is a process. It can be hard and it's a complete lifestyle change. So it's really important to have a solid quit plan. Most people don't just wake up or leave the hospital and be tobacco free. It just really doesn't work that way for the biological aspects of this addiction that we've talked about, and because of our society that we live in. So it's really important to have a plan and to get really good support to make this process a reality. What we do at M Healthy Tobacco Consultation Services, Annually, we'll give out thousands of quick kits that include resources and support, things that help with oral fixation to help prevent that weight gain that we've talked about, whether it's cinnamon toothpicks or some type of candies, sugar free, of course. Um, with the COVID-19 pandemic, we've had to adjust a little bit or pivot. And that's a word I think we've all been hearing a lot lately. And our quick kits have gone virtual. So the quick kit is available online through Tobacco Consultation Services website. I know we're going to list the link in our notes. And I really would encourage those that are interested in quitting to check out the virtual quick kits and what support and resources are available to us. Our outreach is completely free and open to anyone that's interested in quitting. You don't have to be a payroll cancer center or even Michigan Medicine for that matter. We just really want to help people quit, and our program is really effective. So we'd love to connect with you to discuss what might be on your quit journey.
Fantastic, fantastic. And anything to add, Dr. Arenberg? You know, so that you've both answered such a broad range of questions, but I know this is such an important topic with so many different aspects to it that I really want to give you both a chance to say, is there anything you think we've missed? Is there anything you think we perhaps haven't touched on? Dr. Arenberg?
One of the most, I think, impactful things that helped me kind of orient my thinking around tobacco is to fight against this notion that tobacco use is some sort of choice. Of course, we live in the United States where we very much value individual choice and individual freedoms, and appropriately so. So anytime you file something under individual choice and freedom that has this sort of third rail quality to it, I want to argue that there's nothing about combustible tobacco that represents choice. And when you think of the vast majority of adults started smoking when they were teenagers. Now, we don't trust teenagers, most of them, with the ability to vote. We trust very few of them with the ability to drive. We don't trust them with the ability to drink alcohol because teenagers are not known for making wise, spur of the moment decisions about their long-term health. The teenage brain is wired to take risks, and the tobacco industry knows this and has known of it for a century now, and has marketed this several billion-dollar marketing monstrosity that Alena has described is aimed at our teens, at their replacement smokers. And so once they get a teen to pick up their first cigarette, many of them are going to be hooked for life. Addiction is not a choice. And so I would like to just leave everybody with the thought is if you promote the notion of addiction as a choice, you are doing free advertising for the tobacco industry, and you should stop doing that. It's not a choice, it's an addiction, and we need to treat it as such. It's a chronic disease. And so we need to give people a chance to relapse and try again. And to my friends and family and patients out there who smoke, my advice is don't quit quitting.
Thank you very much for that, Dr. Arenberg. Alena Williams, anything to add from your end? Anything you think perhaps we've missed?
I just want to encourage people to really get support through tobacco treatment programs. There are a number of programs out there. You don't have to do this alone. There are a number of factors that contribute to why you use tobacco. Like Dr. Arenberg said, when you start something so young, like most people do, I believe it's 80 to 90% of people start smoking before the age of 18. This changes your brain chemistry. You have more nicotine receptors in your brain than the people that don't smoke. And we really need a comprehensive approach to address that physical aspect and then the societal factors that we deal with to address the terrible things that the tobacco industry have done. Um, Tobacco treatment, I promise you, it can be painless. My job is to really make this process something that, one, you benefit from, and two, that you leave with something. Even for people that go through our program and don't necessarily quit, my hope is that they'll make another quit attempt or that they've gotten something from our program that makes the possibility of actually quitting a reality. And that can take some time. Sometimes it takes 3, 4, 5 times, if not more, to get this done. But there is non-judgmental support available for you for free. And there's also nicotine replacement therapy and cessation medications that can really be a game changer for you. A lot of those products are covered through your insurance. If not, they're also available for free through the Michigan Tobacco Quit line. So please feel free to reach out to us if there's anything that we can do to support you on this quit journey. We would love to connect with you. I would say some of my favorite people are smokers or former smokers, and we still have some work to do. But again, it's just one part of people's lives, and we have to figure out ways to bring more holistic, healthy things into our life to really help us kick the habit.
Fantastic. Well, really thank you both for this great discussion. Thank you for your time and your expertise. Thank you to our viewers with the questions, and be sure if you're watching to look out in our comments section for important links and contacts that we'll push there as well. So thank you both very much and have a good afternoon.
Thanks, Ed. Thanks,
Yeah,
Alena.
thanks, Ed. Thanks, Dr. Arenberg. Take care.
Bye.